we move on to the second presentation, may I have the pleasure of inviting Professor Sachin Talwar. He's a professor of cardiothoracic and vascular surgery at the All India Institute of Medical Sciences, New Delhi. Professor Talwar joins us to speak on congenital heart disease, when to intervene surgically.
Well, I've been assigned to speak on when to intervene for congenital heart surgery. I'll try to make it brief and avoid the controversial areas. So the important thing is a child a small adult? I would say no, a child is a father of man. It just happens that the adults are big kids. So when we go on to understand the philosophy of surgery for congenital heart disease, my colleague was just now talking about interventions. So east or west, all of us have our own philosophies. But you know, we surgeons tend to always have the last word. So I would leave that discussion to a future debate. But why do we need to know about when to intervene surgically? Because you know, we need to assess the risk of an untreated lesion. We need to prognosticate, and definitely we need to follow these patients. And let me tell you something. At this time, we have advanced to a stage that the weight and size is not limitation. This is a 700-gram kid who underwent a successful open heart, and you can see that he barely measures the size of my hand. At the same time, we don't want to get into this problem. This patient who had a ventricular septal defect diagnosed at 6 months of age, for some reason got followed up medically, then lands up with a frank Eisenmenger syndrome. So naturally we know that when you confront a patient like this, who is clearly operable, he comes to you later on and then develops frank clubbing and becomes inoperable. So this is, you want to intervene in a patient who comes to you before that. So because this patient is clearly inoperable, and whatever you might do for this patient, he's not going to make it. So the idea is to pick up these patients before they get into this spiral. And we all know that pediatric cardiac surgery made its birth in 1938 when first PDA was ligated, and since then it's rapidly progressed. Now what does it offer? It can offer a variety of things. It offers a heart transplant, it offers single ventricle procedures, it offers corrective surgery. But the basic operation which most of us end up doing and which most often gets delayed is a simple ventricular septal defect. Now, you see an echo, you see a VSD, and obviously it's not an emergency. The problem is a lesion doesn't get picked up, the child has a coarctation. So what is the natural history of a VSD? We know that if the VSD doesn't close by 12 months, there's only a 25% chance that it would close. So be aware of one thing, that we are not looking for the size of the VSD. What is more important for us is the hemodynamic consequences, what result as a result of the VSD, and that should decide the timing of the operation rather than the absolute size of the VSD. So however, if you have a large VSD, which is producing a hemodynamic compromise, which is producing repeated symptoms, then it does make an indication to close it by 6 months or latest by 6 months. However, if that is not the case and the VSD is moderate, then probably you are justified to wait and you could individualize. However, a VSD is very small, it's a 3 millimeter VSD, but the patient is developing aortic regurgitation, or he has an episode of infective endocarditis, then surgery is probably the best answer and he should be referred early for surgery. What about the atrial septal defect? Now, I do respect the fact that many of these patients are having the interventional closure these days, but any patient who is symptomatic, developing arrhythmia, developing pulmonary hypertension, the baby is small, still he should have an elective closure as early as probably 2 years. So the traditional criteria that the elective closure should be done later in life probably does not hold. And especially if the child has an associated mitral valve lesion, or he has a sinus venosus defect, or has a problem with the left ventricular outflow tract, such atrial septal defects should probably be closed early in life. The patent ductus arteriosus, we know it could be an isolated duct, or it could be the PDA in a premature child, and these PDAs should be closed at the time of diagnosis and should be done as early as possible in life, because the PDA is an operation which has got a nearly 100% success rate. It has got a very, very fast recovery, and it do not require any blood. The aorto-pulmonary defect should be repaired at the time of diagnosis, and we elect to perform a patch repair on cardiopulmonary bypass. Yes, I do agree, as the previous speaker said, that some of these patients are candidates for interventional closure, but those patients who have got a large AP window, those patients who have got a distal AP window, those patients who have got their switch arch problems. Now, these are the candidates who require the early surgery, and they should be done at the time of diagnosis. The atrioventricular septal defects are defects which can be very catastrophic, and they tend to be associated with syndromes, and they should also be done at the time of diagnosis, preferably as early as 2 or 3 months of age. And it is now extremely rare to be able to do a pulmonary artery band in these patients, because that at least we do not practice anymore. Now, coarctation of the aorta is a lesion that has always baffled people. You know, it's a narrowing of the isthmus, but enlargement of the mind. So it should be done as early as possible, and I would differ with the previous speaker that coarctation should be repaired as early as possible. And balloon dilatation and placement of the stent is a risky technology in neonates, especially those of them who have a large PDA. It is best suited for children who are older and do not have an associated ductus. An interrupted aortic arch is another form of coarctation in which the distal aorta is perfused by a duct, and again it should be repaired at the time of diagnosis. Now, the BT shunt is a systemic to pulmonary artery shunt that is basically done to alleviate the hypoxia, and it could be done for indications like tetralogy of Fallot or for any condition in which the pulmonary blood flow is reduced. The interesting part is the tetralogy of Fallot, which is the most common cyanotic heart disease, and the first procedures for the tetralogy of Fallot were the ones which were done for the cyanotic heart disease. And you know, now in the present era, the mortality for tetralogy of Fallot is very, very low, and they have excellent quality of life, to the extent that the world's first tetralogy of Fallot patient is now a professional musician 41 years after his surgery. The youngest patient who had surgery is now a general surgeon, and the oldest of the cohort is now a grandmother at 85 years of age. So this lesion is very gratifying. So again, there is no point in following up these patients. They should be repaired as early as possible. The outcomes in these patients are very good. The transposition of great arteries, a prototype lesion for the transposition complex, should be repaired in the neonatal period, irrespective of whether they have a VSD or an ASD, because if these patients become, I'll just finish in 2 minutes time, if these patients become older, then they would end up having an atrial level repair, which do not have as good result. Now, single ventricle is a volume loaded ventricle, and they would usually have a stage operation. The first stage would be a blalotoxic shunt, then second stage would be a Glenn shunt, that is SVC to pulmonary artery anastomosis, and the final stage would be a Fontaine type of an operation. The truncus arteriosus would again have a complete repair at the time of diagnosis. The TAPUC would again be repaired at the time of diagnosis, and these are some of the lesions which are those lesions which will require surgery as a neonate. Dr. TAPUC, the truncus, AP window, absent pulmonary hypoplastic left heart syndrome. So important thing is that these patients will have very good surgical outcome because they have one step and corrective procedures. So the important thing is that we should have hope, because if it was not for hope, the heart would break. And the era is approaching when the time of the hazard to the patient is not while he is under the surgeon's knife, ma'am. It is not while the patient is under the surgeon's knife, but it is actually before the child is referred to the surgeon for surgery. And as we know, despite advances in the cardiology field and in the field of interventions, pediatric cardiac surgery continues to be a fascinating science. It is broad enough to interest everybody. It is difficult enough to satisfy the ambitious, and it is new enough to stimulate the imagination. So therefore, the timing is of paramount importance. The outcomes of all lesions are excellent, and all of these are one-step procedures. You just have to reassure the parents. You just have to standardize the outcomes, and you have to send the patients timely, because all of us, we share a partnership. We share a partnership in courage. We cannot coexist without each other, and thank you very much for your attention.
Thank you very much, Dr. Talwar. I think Dr. Lakshmi wants
I just want to make a very nice presentation. But however, I never said that we stent the neonatal coarctations. They're only in the Germany, they are doing the biodegradable stents, but otherwise we don't stent. And regarding the BT shunt, I'm not sending any of my patients for the BT shunt. What we do is we cross with the floppy guide wire, open with the PTCA balloon. So even the sickest child with the severe hypoxemia, we do the balloon dilatation of the pulmonary valve so that the antegrade flow and the pulmonary arteries grow, and then they can go for surgery after 3 to 6 months. So that is a thing.
I would love to have a debate with you someday on this.
Yeah.
Maybe this is not the appropriate forum for that. I would love to have a debate. Thank you.
Thank you. Thank you very much, Professor Talwar.